Yep.
Chapter 15, cardiac emergencies for the EMT, also known as cardiology. So this is all review of the circulatory system, which really you should refer back to my chart in anatomy class. This is the right side, this is the left side, this is going up into the aortic arch, and then up to the brain, down to the body. Blood is here, the pulmonary veins, right? Pulmonary veins, and that's what's bringing the oxygenated blood from the lungs. Superior and inferior vena cava. You should recognize all of these structures. So really, it's review, oxygenated, deoxygenated. In blood, you have red blood cells, white blood cells, platelets, and plasma. Review. Let's talk about how electricity travels through the blood. No, through the heart. So all this that we spoke about here is how the blood moves from the body to the heart, to the lungs, to the heart, and then up back to the whole body. Now we'll talk about something completely different. Now we're going to discuss how the electricity moves throughout the heart. We know that the heart has special muscle cells. We've spoken about them. And this cardiac muscle, the myocardium, is really the only part of the body that generates electricity. Generating electricity all starts here in the right atrium in this place called the SA node. The SA node is the first thing that generates electricity, and it sends through special, we can call them wires, okay? But in medicine, we call them pathways. It goes to the right, it goes to the left atrium. Here's just showing more the right side. So these are pathways, and the electricity then comes to the AV node. So we started in the SA node, and then we have the AV node. Let's go further. The AV node sends the electricity down through the bundle of His. That's how it's pronounced, H-I-Z, bundle of His. And that splits into the left and right bundles. Okay, now when you read EKGs, and one day, many of you, some of you will become paramedics, you'll learn way, way more about this. EKGs are the way we look at the electrical flow through the heart, and it tells us tremendous amount of information. The left and right bundles end with these Purkinje fibers right at the end, okay? So that's how the heart beats. Starts SA node, AV node, and then goes to Purkinje fibers, makes the heart squeeze. Understand that these are also backup systems. All right. So if the SA node gets sick, fails, decides not to work, goes on strike, who cares? The AV node will pick up and will say, hey, no one's sending electricity. I better start doing it. Now, the AV node is not as strong as the SA node. SA node can pitch 60 to 100 in a minute. And that's your main, what we call pacemaker. The AV node can only do 40 to 60. So you can see right away, if somebody is that bradycardic, medics are going to be called. We're going to put on a EKG, and we're going to see where is the heart generating its electricity. Is it from here or is it from here? As the patient gets weaker, sicker, and I mean the heart, not the patient will automatically also, then the AV node can also give up, and the Purkinje fibers can initiate a beat. The problem is, the best they can do is 20 to 40. That's the best they can do. So you see that if we get it from the right place, we're doing 60 to 100. Here it gets slower, and here it's really Brady, really, really slow. And these patients need pacemakers. Okay, so anybody with a pacemaker probably had a problem with the SA node. All right, so this is the topic for tonight. The heart itself is a muscle. As such, being a muscle means it needs to get oxygen. It needs blood flow. Great. So all the blood that is inside the heart, where does it go? It comes in to the right side. It goes to the lungs. It comes back to the left side. It goes up into the aorta, and it goes to the whole body. Where does the heart get its own blood supply, or a better word, perfusion? What perfuses the heart? So the answer is the coronary arteries. Okay? Now, these are arteries that are found on top of the surface of the heart. These are called the coronary arteries. These are really important. The coronary arteries come right off of the aorta. So guess what? As soon as the left ventricle gives a squeeze and sends its blood up through the aortic valve into the aorta, the first place to get blood back is the heart itself, the myocardium. And you see here on the picture, you see numbers 2, 3, 4. You do not need to learn the names. I typed them here just so you should know if you hear medics talking about the LAD or the RCA. These are common things that medics talk about. But you don't need to know exactly where they are, what they do. These are the coronary arteries, and this is what's keeping your heart alive. Obviously, the heart is keeping the whole body alive. So we're going to talk about, everything we talk about now is going to be affecting the coronary arteries. So we know there's 5 to 6 liters of blood. Looks like they've gone now with 6. 5 to 6 was too confusing. These words you really don't need. I taught it over the years. I never saw a question on it. Take my word for it. Pulse is how many times a minute the heart is beating. You know that, right? Rhythm and quality, right? Is it regular? Is it irregular? Is it weak? Is it strong? Blood pressure, systole and diastole, right? When we taught you how to do this, and you're going to practice this more. Perfusion, the word perfusion means circulating oxygenated blood to every single organ, tissue, and cell in the body. Okay? Hypoperfusion, this is a word that I explained to you a long time ago, means shock, right? Not enough blood or oxygen circulating. All right, so here is the problem, okay? As we get older, we start eating worse and worse food. Now, I couldn't find a picture of gala or pacha, as we call it, but I found cheeseburgers. So this is the problem. As we get older, the food that we eat starts to get in the way. And we start to build up fat and salt deposits. And guess where they sit? In the coronary arteries. So we're going to talk about it. So we call this coronary artery disease, or CAD. And you must know these two words. These I call the two big words that begin with A. Okay? So atherosclerosis and arteriosclerosis. Now, sclerosis just means hardening, right? Hardening, gets hard. Atherosclerosis, arteriosclerosis. It could be fats. It could be salts, calcium and salts. It doesn't matter. Both could be either. I made the decision to go with this definition for this word and this definition for this word. On tests, they could switch it. So it doesn't matter. They'll never ask you to choose one of these two. Okay, so atherosclerosis or arteriosclerosis, either definition is good. What happens is when we have too much of one of these, too much coronary artery disease, we get a blockage. All right, so let's take a look. Over here, we see we have some fatty buildup in the arterial wall. This is one of the coronary arteries, but blood is flowing beautifully down and giving perfusion to the whole heart. Great. All of a sudden, we get too much fat deposit, and this breaks. And now the fat starts to get out and starts to mix with the blood supply. Okay, we're still getting blood through. All right, blood is still able to get through until this happens. Now we have blood, red blood cells, platelets, everything is meeting over here, and there's no circulation past here. Okay, and this is the definition of a heart attack. All right, this is a heart attack. I'm going to show you the words that we use. Here's a healthy artery. This is a 3-year-old probably. Then as you get a little bit older, you start to build up some fatty deposits. It gets more and more until we have a nearly complete blockage. Now, you have to understand that during normal blood flow, there are clots that flow in the blood. So a clot that flows through here, or even here would be no problem. It'll get through. What happens when a clot comes here? It's going to completely block. And that's called a complete blockage or a heart attack. All right, so this is what it means, coronary artery disease. There's no way to see this in the field. You would have to do something in a cath lab to check this out. And these are the words that we use. Ischemia means this. This is the ischemia. There's less blood flow getting through. Less oxygen, less blood cells. Infarction is death of tissue because anything below here isn't getting any oxygen, isn't getting perfused. And so we're going to have what's called an acute myocardial infarction. That is the full name for a heart attack. Acute, because it happens to blitzling, right? It happens suddenly. Myocardial infarction. This is shortened to AMI, and we shorten it again, just call it an MI. Everyone in medicine knows what an MI is. It means that we're going to learn about how we're going to see this and what we can do and help and whatever. Does everybody understand these pictures? Is it clear what's going on? I need you to understand the concept of coronary artery disease. So there are a bunch of things that fall under coronary artery disease, sometimes called acute coronary syndrome. I won't worry about this so much. Angina pectoris. So we shorten it to just the word angina. You'll hear medics, even EMTs, talk about angina. The deal with angina is that the patient is having chest pain. Just a hint, chest pain is what comes from lack of oxygen to part of the heart. That's the way you know, okay? That's the big red flag, okay? So angina is where they were having chest pain. And then let's say by the time you got there, they're no longer having chest pain. Why not? Okay? An MI does not fix itself. Angina can. So anybody that tells you, oh, I was having chest pain, it was tight, it was pushing, it was on my chest or whatever. Okay, and now I'm 100% fine. They're going in. Okay. Just like in the airport, you don't make a joke that, yeah, this case got the bombs in it, and this case is okay. You don't make that joke by check-in. We don't take chest pain ever not 100% serious. So it's the same type of thing. Someone had chest pain, has or had, we don't care. They're going in, they're getting checked out. So that's the deal with angina. They will have questions on it and tests and things. You have to decide. So 90% of the time, the answer will be MI to any cardiac question. If, however, there is no MI answer and the pain goes away and there's an angina answer, that would be the answer. Signs and symptoms of an MI. These are things you've got to learn, you've got to know. So the number one is chest pain. It's not pain like stabbing. It's pressure or crushing on that chest. It can often feel like indigestion. It's difficult for the patient to, make a difference between them. But let's just go with pressure, crushing, feels like someone's standing on their chest. Any of these descriptions, that's legit. Okay, that's real chest pain. Sometimes they have referred pain, jaw, left arm, back. Sometimes, okay? Feeling of impending doom means they think they're gonna die. It's also a symptom. Now, some people think they're gonna die every day. So you have to check with the family. Is this type of a hypochondriac that always says this? Or is this someone who's a serious patient who never gets sick and never has a problem, and they feel something is very wrong? Denial of severity. This is, unfortunately, in our community, very prevalent. They want to blame the cooking, they want to blame the chulin, they want to blame the shviga. There's a million reasons why they don't think it's an MI, and you have no way of knowing. So my go-to way of convincing them is, look, you could be right, but you had chest pain or you have chest pain. You and I both don't know right now. in your living room. So we're going to the ER, and they're going to do some special blood tests. Oh, I'll go to my doctor tomorrow and get the blood tests. No, your doctor cannot do these blood tests. Okay? They can, and this is true, they can only be done in the emergency room. The tests are known in the field as troponin or cardiac enzymes. These are the ways that we refer to the tests, okay? Cool, pale, clammy skin, obviously has to be with the chest pain, not just, because they're not going into shock necessarily, but they have similar symptoms. Pain not alleviated with rest. So you're going to learn to ask, what were you doing when the pain began? In New York City, the most common answer is shoveling snow. Also during workouts and exercise, right? And you stopped, you sat down. Do you feel better now? No. Okay, so it's not alleviated with rest. Levine sign, this is Levine sign. This was the best picture I could find. Somebody may clutch their chest, left chest, and it's just a sign. This, one of ours developed this and called it after his name, Levine sign. SOB, shortness of breath. Yes, some of them very much, some of them not so much. This may follow physical exertion, meaning, like I said, working out or whatever, maybe following emotional distress. And it may be that they were at rest, sitting, reading, whatever, not doing anything particular. So this is a good beginning of understanding signs of an MI. Okay, 3 people can have a silent MI. Don't forget this when you get out there in the streets. Who are the 3 people? The elderly, male or female. Here, he's representing the elderly. Diabetics of any age, and postmenopausal women. So let's say women over, what number you want to give? 55, 60, whatever number you want to give, okay? These 3 groups of patients may have a silent MI. Why is it called silent? No chest pain. No chest pain. They have weird, vague other symptoms, okay? Any of these. This is my favorite one. An overall feeling that something is wrong, okay? They don't even know what. They just know something is wrong. And I've had female patients postmenopausal, and they told me something's wrong. Have you ever called an ambulance before? Never. Something's wrong. They don't know what exactly. They can't pinpoint it. I knew it was an MI. Took her in, got her worked up, no gains. So having chest pain isn't always the answer. It's good for many patients, but remember the silent MI. Okay, here we have more pictures. Nice coronary artery. Here we started to have a few too many burgers. And here we have almost a complete occlusion. Okay, this is going to be chest pain. All you need is one blood clot to sit there, and boom, there is no blood flow. So, ABCs. Here I put give oxygen. Today we're saying a little different. If they have 94 on the pulse ox or higher, you could withhold oxygen. Position them in POC, position of comfort. Make them comfortable, whatever position they feel best in. Minimize movement. Don't let them walk to the bus. You want to put them on your chair and take them. Always get ALS. If you wait for ALS or not, you have to decide transport time versus ALS getting to you. If you can get to the hospital quicker, you just go. Constantly reassess vitals.
Any reason why you didn't mention diaphoretic? The word diaphoretic, I mean?
I did.
Oh, okay.
In the symptoms right here.
In the symptoms.
Oh, cold, pale, and clammy. Okay, cold, pale, and diaphoretic.
Yeah, okay.
Diaphoretic is an extreme sweat that makes no sense. Okay, so you're in a nice, cool, air-conditioned room, or it's the middle of the winter, or whatever, and all of a sudden there is a sweat. It goes through undershirts, it goes through shirts. It's out of control and unexpected. Right? It's not somebody that did a marathon. You ran a marathon, you're expecting them to sweat. Okay. Here you have the pictures again, nice and clear, starting, getting worse, and getting really bad. So, treatment of an MI will be 4 81 milligram chewable aspirin. Again, why are we giving aspirin? Because we don't want to make the clot worse. Okay, we don't want, like I showed you in some of the pictures where there's more. See here, could just be this one little thing blocking. But then if we thin out the blood, we won't get any more attaching to it. It's not for the pain, and it's not going to stop the MR. That's the aspirin. Now, nitroglycerin, they have to have been prescribed, as I told you. They must have a high systolic pressure, 120 or greater, and it goes sublingual under the tongue. Genetics, reassess vials every 2 to 3 minutes. You can give 3 doses if the medics are not there, at least 5 minutes apart, and with a blood pressure in between each one. Okay, remember, as soon as the blood pressure goes below 120, you cannot give the nitroglycerin anymore. Medics, we can bring the pressure up and down easier. We have that ability, so our rules are different, but this is for the EMT. Angina pectoris, we spoke about it. It's exactly looks like an MI. You will not know if it's an MI in the street. You will know that they have the chest pain, but it could come and go. Give them oxygen, give them aspirin, give them nitro if they have it. Okay. Understand what the nitro is doing. Let's just go back to a picture. Let's say here, if we dilate this artery, we make it bigger, wider, then the clot may be able to move through, and we may be able to perfuse further down into the myocardium. So that's why we use these drugs. CHF we did during respiratory emergencies. CHF in itself is not an acute problem. It's something they live with for the most part. They could have big swollen ankles. They could have some fluid in the lungs, shortness of breath. Again, not usually we're getting cold. Usually they have CHF. Cardiogenic shock we spoke about early on. No nitroglycerin, even if they have chest pain. Anyone tell me why?
The blood pressure is already very low.
Right, in cardiogenic shock, they'll have very low blood pressure. It looks like an MI, okay? But they'll have low blood pressure, possibly tachycardia, fluid in the lungs, but low blood pressure, no nitro, even if they have it, even if you know, it looks like having an MI. No, cardiogenic shock. Remember, shock, low blood pressure. APE, I told you before, we used to have APE calls 2 or 3 a week. Now, maybe 1 a year. Like, they're managed so well these days. Acute pulmonary edema is where the lungs fill with fluid. Backup, usually it's left-sided backup in the heart, and pump failure. It looks like an MI, but they will have very, very high blood pressure. And as I always say, it'll be so high, you'll think you took it wrong. Okay, it'll be 260 or 280 over whatever. If it's so high that you think you made a mistake, get their shirt up and listen to their lungs. If you hear rails, that's the name, rails, that's fluid swishing around in the lungs, then they're in APE. APE, you'll need a CPAP machine, which EMTs are allowed to use now. They may have pink frothy sputum that is coming out of their mouth. Like literally there'll be blood tinged sputum coming out of their mouth. These are all signs that this patient is in APE. Treat them. Get medics. You're now allowed to do a 12-lead EKG. The New York State says acquire and transmit. Well, to acquire, you got to know how to do it. So I will, God willing, teach you on a skill night. There are 2 sets of leads, 4 and 6. So there's 4 limb leads, which goes salt, pepper, ketchup, relish. Remember that. And then there's 6 chest leads. All right, and we'll do it as a skill. Here's the CPAP. We showed it to you, I think, the other night. It's approved for BLS use. It's a tremendous, tremendous tool. And they have to be conscious and they have to be over 18. So, you know, you got to have that. They're in APE, put them on the CPAP. Ventilators usually not used by BLS, used on transport, ambulances from one facility to another. We get called a lot for hypertensive emergencies. That's where blood pressure is too high, too high. This is not an ALS call, usually, okay? Just take them to the hospital. Systolic over 160, diastolic over 94, this becomes a hypertensive emergency. If you think they're having a stroke, well, you have to test them for that. That's something we're going to learn later. Tinnitus, ringing in the ears, nosebleeds, but just the high blood pressure, nothing. We're not going to reduce the blood pressure in the field. We're not going to. We have drugs that can do it, but we're not going to. It's not good. Okay, this is a jello on a plate, and the plate is being moved. When the plate is moved, look what happens to the jello. All right, in English, you would say this is quivering or schockelt sich. Okay, in medicine, this is called fibrillation. And when somebody dies, it's very likely that the heart will do this. When the heart does this, there's electricity flowing through the heart. On EKG, it would look like this. And we call this VFib, ventricular fibrillation. It's the most common way people die. It doesn't always last very long. You could have a patient that died. You get that 4 minutes later, put them on the EKG, you may not see this. So I just want to discuss this one rhythm. It's called ventricular fibrillation. And this needs a special machine called a defibrillator, and we'll discuss this when we do AED. But this is the machine that you see now in public places, in schools, in movie theaters, in airport. I always check in the airports when I fly, in big train stations, anywhere where there's a lot of people, you will see a defibrillator. We'll teach you how to use it, teach you what it does, what it doesn't do, but defibrillation stops this fibrillation. It's not like a dead battery in the winter where you're jumping a car with another car. It's not that at all. Just the opposite. The patient's heart is doing this. You use a defibrillator to stop this. You use CPR to get it back into a normal rhythm. So it's not what people think. It's not jump starting the heart. It's stopping the heart, stopping this death. Okay.